Robert, I just have a few questions that I've been asked to raise by the recognised legal representatives. In your evidence, you talked about the stigma that people faced and the approach of haemophilia doctors in relation to maintaining treatment within the haemophilia centre. To what extent was that evidence based on your own experience, or was it a reflection of your understanding of the experience of other infected people within the community?
It was a reflection on other people, both meeting them through Birch Grove meetings, weekends, the McFarland Trust events, some of the life history stories, also people talked about that. No, I went and saw another doctor because I just thought this was silly. So in terms of HIV, I actually went to a different hospital because that was where there was a specialist AIDS clinic, and that made a lot more sense to me.
You also spoke about your view that the stigma affected the attitude to risk. Do you mean that the lack of belief amongst haemophilia clinicians that their children could be infected with this disease affected their attitude to the risk that it might happen? In other words, that they underplayed the risks because they didn't take them as seriously?
Yes. I'm not sure if it was not taking it seriously. I think it was disbelief, and their group, our group, their children, compared to this disease of pariahs, as I put it, and just not being able to see that group as related, and therefore not being able to deal with that risk in a rational, calm way and make assessments about it.
But by children, for the sake of the transcript, we probably need to put inverted commas around it, don't we?
Yes.
That's how you've been using it. That's how I've understood it.
Yes, I did notice. I think Professor Colvin actually did use the phrase as well. He talked about his children, I think, is when he talked about his patients. But yes, that notion of us as children. Okay.
I'm sorry, as it's written down, it's got inverted commas around it, but obviously in the transcript, it's
not on the transcript.
Thank you. When you spoke about the interplay between that stigma and the treatment that people received, in your evidence today, you said that many haemophilia doctors didn't go to conferences like other doctors. In your view, why did haemophilia doctors not network or share their experience in the same way as others?
I think there was, to some extent, a lack of interest in HIV and hepatitis. Their own conferences, I think they saw as the primary source for their information, rather than it being other conferences in other specialities, apart from the couple I mentioned. I think they just didn't see them as big, important meetings that they needed to find out things about. There was a paper written a bit later by 3 clinicians about the increased level of bleeding if you were on a particular HIV drug protease inhibitors. And I had never seen any of the 3 authors who were haemophilia doctors at an HIV conference anywhere. Any of the regional updates from international conferences, I'd never seen one. I'd never heard of them going to a conference. And I think there was one HIV clinician involved in writing the paper, but it just seemed to me bizarre that they were writing it. And I suppose maybe they had to because they were haemophilia patients, but they just, I suspect they didn't want to be involved in it. Even the medical profession, particularly at the beginning, there was a stigma attached as a doctor working in that field because of the patient groups, and therefore other doctors were probably less comfortable about going to it.
In your evidence, you talked about the fact that your view was that haemophilia doctors had got it wrong twice, and we talked a little bit about the impact of that on the patient-doctor relationship. In your own experience and the experience of those who you've met through things like Birch Grove, did doctors try to confront that difficulty of trust in terms of the management of ongoing treatment, or was it something that was just parked and ignored? You may not be able to generalise in that.
Yeah. I can't think of anyone ever talking to me about a clinician who ever raised it in those sorts of terms. The closest I can think of to this was at, I think it was a Haemophilia Society conference, and there was a pharma company and they were giving away soft toys. There were little dolls, and the doll was orange. So I made a joke to the rep giving it away that it's nice you've given them hepatitis. And the rep's response was, oh, I hoped we were past all that. But I can't think of any doctor who's done it, who would have done that. Certainly not one at the time. More, I think, not wanting to confront that issue.
Different topic. We talked about the work you did in lobbying to change the guidelines for the treatment length of hepatitis C treatment. In that time that you were lobbying in relation to the treatment, was it ever suggested that extending the period of treatments could lead to unintended resistance to, for example, interferon or ribavirin?
There was discussion about the idea of interferon resistance. No one had ever actually demonstrated it really existed, but there were obviously people for whom it just didn't work. But whether that was because the virus was somehow resistant to interferon, or it was just your immune system couldn't build up and get rid of it, was never confident. And there was almost the opposite point of view, which was that, well, if you're taking it and you get what's called a breakthrough, so you can now detect hepatitis C in the person, then you stop. Obviously, it's not working, you stop. And that would be the situation where you'd be thinking maybe someone's resistant. If they're still undetectable for hep C at 6 months and you continue for another 6, even though it may come back as it did in me, a few weeks after that, no, there was no... It wasn't seen in that sort of way, I don't think. It was talked about very differently, say, resistance to HIV drugs, where we certainly had tests after a while of resistance for HIV drugs.
And finally, we talked about patient voice. What role do you consider advocacy organisations require to play in future?
To bring out the patient voice, I think to be aware in particular that when it's working with something like the NHS, the government, those are large organisations that have inertia, they move very slowly, and the decisions they make it's always easier to stay the same, to not decide, to keep things going. And one of the important roles of advocacy organisations is to think about it in different terms. If we were starting now, would we do this? And if the answer is no, then it should be lobbying, we don't do this. The advocacy organisations are meant to be annoying. We're meant to grate against, yes, we accept all the wonderful things, thank you, that's lovely. Now can we talk about the difficult things? I do think as an advocate, we need to work in cooperation. You need to think about it and do things and not ask for the impossible. But you've always got to be optimistic and want what's best and push for that.
Sir, do you have any questions you wish to raise?
Yes, I do. There are two questions, really, but they're both fairly broad areas. The first, coming back to stigma, because you've thought about this, you've discussed what might be the causes of stigma, you've discussed how it may have infected patients with haemophilia as well as patients in GU clinics in different ways. What would be your ways of minimising or even avoiding stigma in future?
I think if we knew how to get rid of stigma, we'd be doing it with a lot of things. And it's difficult. One of the things that I think is important is visibility, to sort of make it appear normal that the group is not the demons that they can be made out to be. Time and a personal contact. the area where I can see the biggest transformation around stigma is around gay people in society, and the change of now back to the 70s and 80s. And I think a lot of that was about visibility, activism of things like Stonewall, and more and more people knowing someone who was gay and getting used to the fact that they were just people. And with HIV and with Hep C, I think knowing someone has such a powerful effect. Hopefully knowing someone you like, but the personal contact in terms of stigma, I think, and also to recognise it's very difficult. We still have stigma around people with mental health problems, and it's been very difficult to reduce that.
Well, thank you for that. The second is to deal with the McFarland Trust. You've been a registrant throughout its history. You've told us quite a lot in answer to Council's questions about the early 90s, when the Reverend Tanner was chair. You've mentioned Peter Stevens on occasion. And you've told us what it was like for those who discussed the matter with you and for you in dealing with the McFarland Trust in the early days. Did it change? If so, how did it change? Did it get worse? Did it get better? That's why I said it's a broad question.
Yes, yeah.
But I'd like to understand your view of the relationships which you had and others around you had with the McFarland Trust through time.
Mm-hmm. As I say, yeah, it was very difficult at the beginning. I found it very difficult when Anne Hithersay was running it. And there was more communication when Peter Stevens was in charge, and I think there were some changes. The events started to happen that might have also been the end of Anne Hithersay's. At a certain point, and I can't remember exactly, I resigned from the partnership group because I felt it just wasn't doing anything and going anywhere. It was just a talking shop, and we weren't having an impact. The user trustees that I knew had great difficulty in the role, and we've heard from some. But the last probably 15 years of it, I actively avoided it. If I wanted money for something, I'd work. I used my job. I didn't want to have any involvement with the McFarland Trust. I would take the regular payment, and I don't think I applied for a single grant for an awful long time. I applied for one for respite after an operation, and they said it was a haemophilia problem, not an HIV one, so they wouldn't give it to me. And after that, I just, this is not worth it. It's much better to get my own money savings, and then I spend it how I want it, rather than ask for it. So, although I heard from other people that it remained pretty awful while Jan Barlow was there, I had no contact with it at all, other than its newsletter. And the only thing I can think of was more recently about that, hearing the description from Eames, the unpronounceable one, of what their special category mechanism application and how much easier it was in Wales, and it made me so glad I was in the Welsh scheme, that not forcing you to kind of go through large amounts of requirements just to be allocated to the right category. So my experience was that it got better if you just wanted a regular payment and it didn't hassle you. But if you were in need and needed things out of it, I suspect it stayed the same.
And what, in particular, put you off yourself applying for any single grants was what? You described the process, the time it took, the bureaucracy. What? Anything else?
I probably was a bit proud in the sense of I'm independent, I can do this, I don't want to be asking and begging for something. And in some cases, particularly later on, I didn't want to have any dealings with the people there. There was a few that I knew had been there quite a while, Nick and Shane and Keisha I would happily chat to, but all the senior people, I just wanted nothing to do with them. And some of the letters from some of the trustees were, put me off as well. The tone and language. The last involvement I had was when they decided they could get rid of their reserves, and they ran a scheme, and they came and someone would come to your house and take photos of your house. And actually in my McFarland Trust file, I found there's 2 photos of my front room. There's no other description of what happened around that, just the photos. And I asked for some money, but I couldn't really think of anything that I wanted it for at the time. And the person who came wrote out a few things, and they said it didn't fit the criteria. But just the descriptions they sent to us about that, the letter, if you want some of this money, you will have to have someone come and visit you. And it didn't quite say we will not pay for frivolous items, but something like that. This is sort of basic needs only. It felt like people who had no idea of the way people lived, who were poor. I mean, I wasn't poor, but the tones of the letter.
Yes, well, thank you very much.
Robert, is there anything else you would like to say at the end?
Yes, there is. I wanted to say, first of all, I've mentioned about people telling their story. I did the Life History Project, but one of the things, and I teach law at university, and I sometimes teach a bit about inquiries, and I've felt for quite a long time one of the values of a public inquiry is that it can give the people who have been wronged or hurt an opportunity to describe how that was for themselves in their own words, their day in court, to use the cliche. And I think this inquiry has done that much better than most other inquiries I've taught about. So thank you. A few weeks ago, we had health ministers on, and Vaughan Gethin from Wales talked about what had happened as being a failure of the state. And to my surprise, Matt Hancock also talked about it as a failure of the state. And I thought, well, we've got there. It's just a pity it's 35 years late and thousands of deaths. And the last thing I wanted to do, we mentioned the unveiling of the stone at the Birchgrove Wood, and I looked up and I saw that happened 17 years ago, 2 weeks and 17 years ago. And on that day, I read out some names to represent the 1,200. I read out 12 names. Now, this inquiry is much bigger than that. It involves people who got Hep C, people infected through blood transfusions, people who got Hep B, people through tissue transplant. So it didn't seem appropriate just to read those same names out. So I wrote down the names of some people who have just been important through my period of life with these viruses and haemophilia, and I was just going to read them out. Caddy, Paul, Gary, John, Martin, Myrian, Kathy, Julia, Praf, and David. Thank you.
You said towards the end of the evidence this morning that an advocate asked about the project which you conducted with Sian Edwards. You said, I think with the catch in your voice actually, that you thought the testimonies were powerful. I'd like to pay tribute to the powerful way you have expressed your views to us this afternoon and this morning. And in particular, what has impressed me is the way in which you have seemed to want to understand the reasons for others' behaviour. in what you've said, searching, as far as I see it, for a reason. You've enlightened us, I think, in a number of respects because of the slightly different angle that you have on the events we've heard about from that of many others. And you've told us that stigma has not only affected those who've been infected directly in the way in which people in society generally have approached them, but also affected those who treat them in the treatment they got or rather didn't get. You put in a powerful plea for the treatment by the specialist who is the true specialist, as opposed to someone who doesn't want to let go of their patient. Curiously, though you are a doctor, because you have a PhD, you have been able to educate doctors who are clinical doctors and others. You describe yourself as a treatment activist, and you've enlightened us again about the ways in which you have been able to educate those who are in clinical authority, probably the best way of putting it, and nurses. And told us as well what it was like, what it felt like, personally and for others, to be a registrant or beneficiary or whatever word was in vogue at the time for the McFarland Trust, particularly in those early years, about which we haven't heard an awful lot of evidence because people have moved on. So I'd like to thank you for that powerful evidence which you've given today, taking full advantage, I'm glad, of what you see as a human right to state your case in your day in court, if you like, as you would wish inquiries would give generally to those most affected by what has happened.
Thank you.
So thank you. Tomorrow we have Bruce Norville, do we?
We do, sir.
10 o'clock. 10 o'clock tomorrow.